a crisis, I don't think I realized at first what was happening because I descended. My symptoms got worse over the course of about a month. And eventually to the point where I couldn't swallow at all, so I couldn't eat or drink anything. And I had a lot of fear that I was going to choke. And I ended up in the hospital getting further treatment. And it was terrifying. I describe it to people by saying I felt like I was drowning every day because the secretions in your throat have no way to clear them. And so they just feel like they're slowly falling down your throat. And the fear is if you drink something that you can't swallow properly, you can aspirate and end up with pneumonia. So it essentially felt like I was drowning 24 hours a day for upwards of a month, which was terrifying. And it wasn't until the treatments started to work that I started to feel less anxious. But I think knowing that that can happen anytime, to me, means that the anxiety over a crisis is always there. And that's when I started on high-dose steroids and long-term immunosuppressants to try to kick me out of the crisis, which worked about 10 days later. But it did involve spending 3 or 4 days in the ICU before getting better. So for me, the process, like that whole crisis, I would say lasted 4 or 5 weeks. But I think they can last less time and they can last a lot more time, which is scary to not really know when you'll come out of it. And I think the fear over that is essentially the suffering that comes with being intubated while the treatments begin to work and you are able to breathe and swallow on your own again. When it comes to coping with a chronic illness, sometimes I think it's almost easier after you've been diagnosed because the symptoms in advance of diagnosis can be very confusing. Once I formally had a myasthenia diagnosis, I felt somewhat more confident in understanding how it would affect my life and what treatment options were available to me. A concern I have with my current MG treatment is the possible long-term side effects of non-steroidal immunosuppressants. And I would love to be on medication that doesn't have these long-term side effects, but I don't know if those currently exist right now.
Good morning, everyone. I'm Kurt Kleefeld, the Managing Director of the CME Institute. Thank you for joining us for this important and timely webcast. Our chairperson today is Dr. Vera Bril, who is with the Division of Neurology at the University of Toronto and University Health Network. I will hand the meeting over to her to introduce Dr. Silvestri and Dr. Barnett-Tapia. Dr. Bril?
It's my pleasure to be here from the University of Toronto and to welcome my colleagues who are co-faculty, starting with Carolina Barnett-Tapia, also from my institution, and Nicholas Silvestri, who is not far away at the University of Buffalo in the US, and a good colleague. Dr. Silvestri is going to talk about where we are now. Dr. Barnett is going to talk about the gaps, and then I'll be talking about some new treatments and the Fc receptor inhibitor story. So now I'll hand over to Dr. Silvestri, who will start us off.
So just to start us off, myasthenia gravis, as many know, is a prototypical autoimmune disease, and it's caused by autoantibodies. And predominantly, these antibodies are against the acetylcholine receptor. They can also be against MuSK or LRP4. And there is a small percentage of patients where we don't know which antibodies they have. We term them as triple seronegative, and their antibodies are yet to be identified. Myasthenia gravis has a bimodal age distribution. It tends to occur in people around 30 years of age, and then again around 50 or 60 years of age. And in the younger age group, females predominate at a ratio of about 7:1, whereas in the older age group, there's a slight male predominance. The incidence is pretty low, as well as the prevalence. We estimate in the United States there's anywhere from 60,000 to 80,000 patients with myasthenia gravis. In terms of pathophysiology, I'll restrict my comments to the most common form of myasthenia, the acetylcholine receptor mediated, antibody mediated disease. And in this case, the antibodies lead to impaired neuromuscular transmission and therefore weakness in our patients by a number of different mechanisms. One of those mechanisms may be by attaching to the acetylcholine receptor and activating complement, causing complement-mediated lysis of the neuromuscular junction. It can cause accelerated internalization and degradation of the acetylcholine receptors, not making them available for neuromuscular transmission. Or it can lead to direct blockade of the acetylcholine receptors, so attaching and functionally blocking the receptors from receiving acetylcholine and therefore causing neuromuscular transmission. Myasthenia gravis is a very unique disorder in that it leads to fatigable weakness. The fatigable weakness tends to predominate in ocular and bulbar muscles, and it tends to cause ptosis or eyelid droop, as well as double vision or diplopia. It can cause dysphagia, dysarthria, dysphonia, or chewing difficulty. In its most severe form, it can cause dyspnea or orthopnea, and it can lead to weakness of the muscles of the body, axial muscles such as the neck muscles, leading to dropped head syndrome, or for the most part, proximally predominant limb weakness, though there are distal forms of myasthenia. In terms of making the diagnosis is history. So a patient with fatigable weakness, which is predominant in the oculobulbar muscles, is myasthenia until proven otherwise. On examination, we can test for fatigability. We can have patients stare at our fingers and see if they develop diplopia on sustained upgaze. We can try to push their muscles, their proximally predominant muscles, their deltoids and iliopsoas, until we can get them to fatigue. Or we can use a very expensive piece of medical machinery, an ice pack, and put it on a ptotic lid to see if that ptotic lid will actually improve, as is the case as occurs in myasthenia. As I mentioned before, myasthenia is due to autoantibodies in most cases. In about 85% of patients, it's due to acetylcholine receptors, around 7% MuSK and about 1% LRP4, and these are all commercially available tests that we can send. In complicated cases or in seronegative cases, we can do electrophysiology, such as repetitive nerve stimulation or single fiber electromyography. And then we can also do an edrophonium test or a tensilon test, which is a short-acting intravenous acetylcholinesterase inhibitor, which will transiently lead to improvement in weakness in patients with generalized myasthenia gravis. So where are we today in terms of treating myasthenia gravis? Luckily, we have many available treatments, but that being said, as we'll talk about, these treatments do have side effects, and at times there is a need for more treatments in GMG. We can do a thymectomy in a patient. We can remove their thymus. We can use immunosuppressive therapies, such as oral immunosuppressants. We can use intravenous immunoglobulin, or fetal-neonatal receptor antagonists, complement inhibitors, or acetylcholinesterase inhibitors, such as pyridostigmine. We have a list of different medications we can use. The more commonly used oral immunosuppressants are mycophenolate, azathioprine, tacrolimus, methotrexate, as well as using steroids to broadly immunosuppress patients. Many patients with myasthenia, if not all patients with myasthenia, at some point are probably put on steroids. In terms of the treatment paradigm, there is some variability here. I think that one of the great things about taking care of patients with myasthenia is that no one patient is like another, and that there are several nuances taking into account patients' age, comorbidities, other medications that we have to account for when we're prescribing medications. However, in the case of younger patients with myasthenia, arbitrarily defined as 50 years or younger, and those that have acetylcholine receptor antibodies, we know that a thymectomy may be helpful. Certainly in those patients with a thymoma or a malignant tumor of the thymus, we also have to offer thymectomy. However, if patients don't respond optimally to the thymectomy, we might consider trying them on immunosuppressants a year or so, or sometimes even sooner after the thymectomy. In patients who are older than 50 years of age, or those who don't want a thymectomy, we often will start with a trial of pyridostigmine. But in generalized myasthenia gravis, acetylcholinesterase inhibitors in and of themselves are rarely potent enough or rarely effective enough to treat completely. So we're often moving on to steroids and then the use of steroid-sparing agents, such as those medications I mentioned before. And if those patients don't adequately respond, we consider either a trial of another immunosuppressant or more aggressive forms of therapy, such as eculizumab or rituximab. And in the case of MuSK myasthenia, we often go to rituximab quite early, as it's a quite effective therapy in the treatment of this particular disorder. There are multiple considerations that we need to take into account. There are limitations of the current therapies. There's a variable time of onset. It can take some of the oral immunosuppressants I mentioned about 12 months in the case of azathioprine, maybe even 18 months to work. Not all of the routes of administration are convenient. We have predominantly oral and intravenous routes at the current time. There are a myriad side effects of currently available therapies. As I'll also talk about, the efficacy is not helpful in every single patient. And some of these medications that we have to treat patients with myasthenia are quite expensive, and we have to some extent, remain cost conscious in our prescribing habits. In terms of side effects, these are seen in about 2/3 of patients with myasthenia, according to the literature. Many of the medications, being immunosuppressants, increase the risk of infection and long-term possibly malignancy. They can lead to dysglycemia, high blood pressure. They can lead to osteoporosis, hepatotoxicity, nephrotoxicity, as well as mood disorders, predominantly depression and anxiety. In the case of steroids, sometimes psychosis. And as I mentioned, these therapies don't work for everyone. One of, again, the great parts about treating patients with myasthenia is it's not a one-size-fits-all treatment regimen, and some therapies lead to side effects in some patients, some therapies work for patients, but some of the currently available therapies still have limited efficacy. And so patients remain quite debilitated in some cases by their disease, is measured by certain scores like the MG-ADL, the MG-II, the MG-QOL, despite current therapy. So the point that I want to make is that though we have many therapies available to us today in the treatment of generalized myasthenia gravis, there are still many patients that suffer from the burden of treatment insofar as side effects or inconvenience, or burden of disease because their myasthenia gravis is not yet optimally controlled. We really do need to be striving for minimally symptomatic or asymptomatic in our patients.
I've been very lucky that myasthenia at a macro level hasn't had a significant impact on my life plans because I was able to finish law school. I'm a full-time practicing lawyer. I have a husband and a baby and a toddler. But I think it's important to understand that on a micro level, I think myasthenia affects my life plans every day. It's a factor in what I do every day. Am I getting enough sleep? Am I getting enough rest? Are the physical activities am I doing, are they too much for me that it's going to bring about more symptoms? I know what it's like to decline into a crisis, and my number one life goal is to avoid doing that again. No one could tell me how long it would last. And every day, I remember being in the ICU, and every time the neurologist would come visit me once a day, and I would say to him, how much longer is this going to last? Like, how much longer before the treatments start to work? And there was no real way for him to answer that question for me. I was in the hospital for 2 weeks, and when I got better after receiving IVIG, I went home. But that wasn't enough on its own to pull me out of the crisis. And about 2 weeks later, I lost the ability to swallow and talk again. We went back to the hospital and said to them, I'm getting worse every day, and I know I'm going to end up in crisis again. But they sent me home. And in hindsight, I really wish I had fought harder for myself, because I stayed at home for another 4 or 5 days until I couldn't breathe. And we went to the hospital, and that was the day that they rushed me to the resuscitation room to put an NG tube in my nose and into my stomach so they could get the medication in, and I ended up in the ICU. And I knew that that was going to happen because I was continuing to get worse, but no one has the experiences that you have where you understand what your normal is and how your normal is declining. And so going forward, I know that I will ensure that I advocate for myself to make sure that that doesn't happen again.
What I always say is that we've come a long way with treatments for myasthenia gravis. So the name myasthenia gravis comes from grave. It was not a good thing to have myasthenia gravis, especially in the early 1900s, where mortality was close to 100%. As treatments became available, not just specific treatments, but as we developed intubation, ventilation, other treatments like thymectomy, eventually neostigmine or pyridostigmine, and plasmapheresis and other treatments, mortality has reduced. So if you look at the curves of mortality from the 1900s to the 2000s, we've come from almost 100% to close to 10%. So yes, we have lots of treatments, and I love treating myasthenia because it's something we can treat. But despite the fact that we've come a long way, what I want to tell you is that we have a long way to go. 90% of patients, so 9 in 10, will get better with treatment. If you look at case series anywhere in the world, most patients do get better. But I'm always concerned about what does being better mean, and that is different from different people. We've looked at something called patient acceptable state. Basically, we've asked patients if they're happy with their current disease state, something as simple as asking patients how they're doing. And when we looked in our site at patients with myasthenia gravis, about 40%, of 4 in 10, were not happy with their disease state. They had unacceptable disease burden. That's 40%. And you may say, well, that's only one center, but if you look across the world, this is happening everywhere. So there's a very nice large study in Sweden from last year that covers almost half the patients with myasthenia in the country, when almost half the patients were not in an acceptable state. Almost half the patients, despite having treatments and accepted treatments and standard of care, were having symptoms that were beyond what they would consider acceptable. If you look at North America, in the Myasthenia Gravis Foundation of America registry, we also see that patients fill questionnaires. They have a very nice registry where patients feel the symptoms they're having. They can do it on a periodic basis, and patients are still having a high burden of symptoms. If you look at Norway, they have very nice big study looking at quality of life. Again, large number of patients that are having non-happy. And that's a problem, because even if patients are better, sometimes we're happy that someone is getting better. Sometimes better is not being well enough. So you can be better from a disease, but if you're unable to work, if you're unable to care for your family, if you're unable to enjoy life, I would say that we're not doing as well as we could. So that's where we can certainly do much better. Dr. Silvestri talked about the side effects of treatment, and this is something we always have to keep in mind, because every time we prescribe something and when patients make decisions, there's always a trade-off between getting better and having a side effect from treatment. Sometimes a side effect may be worse for a patient than the symptom you're treating, and sometimes it's the opposite. So every time we're balancing this, and it's a very individual decision, because first, every patient is different, their disease is different, they have different lifestyles, different demands, and different comorbidities. So we always have to take this into account. But we know, for instance, that the prednisone side effects are a major concern for most patients. It's a wonderful, horrible drug at the same time, because it's very effective for myasthenia, but almost everyone gets side effects. People gain weight, people get osteoporosis, pathologic fractures, mood swings, headache, and everything that Dr. Silvestri already mentioned. We also know that any immunosuppressant therapy has increased risk of infections, and that's a problem because they can be quite severe. So we looked in Canada, in Ontario a few years ago at the populations by level, looking at thousands of people with myasthenia gravis, and we saw that patients with myasthenia had sometimes 2-3 times the risk of having respiratory infections leading to hospital admissions, shingles, and other infections compared to people without myasthenia, which shouldn't surprise anyone who has treated people with myasthenia, because we're actively immunosuppressing them. So any treatments that may immunosuppress less or are safer from that perspective would be welcome for patients. And of course, now with pandemic, people are more concerned about infections all the time, and we're thinking about these things all the time. And there's this potential risk of cancer that we really can't really quantify. So it's hard to tell patients how big or not that risk really is. So I always think about what would be a perfect treatment or a perfect drug. And the perfect treatment would be something that's 100% effective, meaning it cures the disease, basically no signs or symptoms. A treatment that works in everyone. So, you give it, 100%. It has no side effects, perfect, just in clinical trials, but also when you do post-marketing data, and that's affordable and easy to implement. And if we had this, we would cure everything, and that doesn't exist. But we would like with new treatments, and as we move forward, is to close this gap and kind of improve this. So finding something that's more effective, that works in more groups, or find the groups in where it works better, reducing side effects and making it accessible. And if we do that, we're going to help our patients. One thing that we sometimes forget is the patient perspective. And I think now there's interest in the myasthenia gravis community of gaining knowledge about what patients are feeling. And there's more qualitative studies where we're interviewing patients and asking them what they feel. And things are coming out, but things that I find is really interesting is what are symptoms that bother patients. And sometimes they're not the same as physicians are concerned about. So clinicians, we're always worried about admission and myasthenic crisis for obvious reasons, because those are the things that, you know, have mortality associated with them. So of course, we don't want patients to come to hospital admitted with myasthenic crisis. So we're always very concerned about swallowing issues and respiratory issues. But for many patients who are living out their normal lives, having double vision is one of the most bothersome symptoms, because it's very hard if you see double. You need double, you know, you need your eyes to read, and you know, it's really, really disabling. So oftentimes for us, we think it's a mild symptom, like we may not be as aggressive treating double vision because, you know, people are not going to go to hospital and be intubated because of that. But often for patients, that is something that's quite disabling. If you think of someone who's a driver, that may completely incapacitate them for work. So sometimes we have to go back and remember what it was that patients told us that was really, really important. The other thing that patients are really bothered is the fluctuations. So if you look at the textbook Myasthenia Gravis, and Dr. Silvestri mentioned this about the fluctuating symptoms, that's really bothersome for patients, because patients can't plan their lives if they don't know how they're going to feel, no matter day to day, even within a single day, right? So you start the day with some degree of symptoms, and it might be completely different afterwards. So it's very frustrating for patients to not know what their day is going to look like, if they're going to be able to take their kids out for play, if they're going to be able to complete their day of work. So any treatment that not only makes people better, but that reduces those fluctuations and provides stability is going to be something that's going to be extremely useful for patients. Patients also feel that there's treatment inertia. So there's a beautiful paper that came out last year that's a patient-led study. So this was qualitative interviews, but the analyses were done by patients with myasthenia gravis. And patients felt that there's some inertia, that, you know, their treating physicians don't want to innovate. It's like, you know, things are working, so why fix it if it's not broken, kind of mentality, where patients feel they're still not as good as they could be. And again, it comes to this trade-off, because as clinicians, often we don't want to risk patients having more adverse effects. We don't want to increase prednisone. We don't want to get patients at risk of an infection. But sometimes we need to, again, go back to remember what is the specific patient wants out of life and out of their treatment. And some patients will be okay, and some patients will say, you know what, I don't want this adverse effects. I'm happy I can manage my life with this degree of symptoms and fluctuations. But some other patients will feel that that is not enough, and then we need to increment. And that's where I feel that there are gaps, because with our current arsenal, sometimes we're quite limited in terms of the side effects, adverse reactions, the time of effect. So some patients have mentioned that they feel like they have wasted time when they have, I'm going to quote unquote, wasted 6 to 12 months waiting for a treatment to kick in when that treatment didn't work. So sometimes with especially older treatments, we need a full year before we see any effect, or before we don't see any effect and we say it's not useful. For that patient, it's a full year of their lives that they feel they wasted because the treatment didn't work. So again, any treatment that would shorten that time for action is something that would make patients' life better and better quality of life. And all these things will impact mental health. Patients with myasthenia gravis have higher degrees of anxiety, depression, and mental health problems, a lot of based from their physical dysfunction and all the things that I have previously mentioned. So as you can see, there are many treatment gaps. So when I think about trade-offs, and when I think about, you know, how to balance out all the pros and cons, for me, and talking to patients and doing research in patient-centered outcomes, comes to making this balancing out, you know, making the balance more even side by side. So anything that will improve symptoms, that's more, you know, efficacy, like symptoms are better, that fluctuations are less evident, that people can plan their lives. So on one side, we have that part covered with less side effects, hopefully, and that's faster action will really help patients move forward.
I think coming to terms with having a chronic illness is an ongoing process. Before diagnosis, I was quite confused about the symptoms, and I think there's some certainty about eventually having a diagnosis and having an answer to why your body isn't reacting the way it's supposed to react. And I think at first I felt like I was coping quite well with having myasthenia. I was still working full-time as a lawyer and trying to live my normal life. But then it wasn't until after I had a crisis, I think, that I fully understood the ramifications of having myasthenia and what would happen if I didn't take care of myself properly. And I think that's something I continue to cope with as I try to work full-time and parent small children. The days are busy and it's hard to prioritize your own health and wellness. But I understand now what can happen if I don't. But I do have to say that it is challenging having a chronic illness that is, one, extremely rare, that no one has ever heard of before. I think the challenges that I have faced have actually been with doctors that are not neurologists, which again, don't always have a lot of background with a rare neuromuscular disease. So, I'm the first patient that my family doctor has ever had with myasthenia. It's interesting going to the dentist sometimes because dentists don't always have a lot of familiarity with it, and they like to give me my cavity fillings without any anesthesia because they are nervous about me. So I try to educate the best I can as a non-medical practitioner, but it can be challenging where not everyone understands how myasthenia can impact it can impact someone. My relationship with my neurologist is important to me because my neurologist has kept me up to date with treatment options. Many myasthenia treatments have been around for a long time, so we have spoken about those over the years. But as new treatments become available, we talk about them to get a sense of why there are medications that she is suggesting for patients or is not suggesting for patients, and why they would be appropriate for me or not.
I'm going to talk about some new and exciting developments in the treatment of myasthenia gravis that has reinvigorated the field. We all know about the complement inhibitor, eculizumab, that was released recently for refractory myasthenia gravis. And now FC receptor inhibitors are being developed. I will just disclose that I'm a consultant for a lot of companies who've developed both, as well as immunoglobulin products. You've seen a little bit about the underlying mechanism of disease that has been provided to you by Nick Silvestri. But we know this is an antibody-mediated disease, myasthenia, and that there's a loss of tolerance with production of abnormal antibody. And we know that acetylcholine receptor is fundamental in neuromuscular transmission for activation of the postsynaptic membrane and muscle contraction and our strength. And we know that various other elements of the neuromuscular junction are important in the function and activity of acetylcholine receptors. So if we produce antibodies against this acetylcholine receptor, what we can see is that the abnormal antibodies interfere with the acetylcholine receptor in several ways. One, by simple blocking of the acetylcholine receptor. Two, by modulating the receptor, by cross-linking, leading to accelerated internalization and degradation, and by complement-mediated destruction. So these are the three main mechanisms, as you know. And if we go on, eculizumab, which has been approved, is effective at the last element of acetylcholine receptor dysfunction, where complement is split and you get the development of membrane attack complex and destruction of the postsynaptic membrane. So this complement inhibitor interferes with the release of complement and the complement activation. And you can see the blocking, and you can see the complement recruitment. What we're really going to talk about now are FC receptor inhibitors. The Fc receptor functions to recycle immunoglobulin. The IgG binds to the Fc receptor and it's recycled. You have the binding and then the recirculation to the cell surface membrane. If you inhibit an Fc receptor, it reduces recycling of immunoglobulin and it delivers the immunoglobulins to the lysosomes where they are degraded. So in effect, it drops IgG levels and it drops all classes of IgG if you're treating with an Fc receptor inhibitor or exposing the patient. So what you're doing is blocking a recycling mechanism that helps maintain immunoglobulin levels in the circulation, including abnormal immunoglobulin activity such as acetylcholine receptor antibodies. Fc receptor inhibitors, what happens is you block this recycling and you block the antibody, reduce it, and therefore all the mechanisms of an abnormal antibody that we reviewed are reduced. All the IgG subclasses from 1 to 4 are removed, and therefore you can expect this type of therapy to work in acetylcholine receptor positive myasthenia gravis, but also in MuSK myasthenia, where MuSK is IgG4. And as you recall, complement is not activated by IgG4, and so complement inhibitors cannot treat MuSK-MG. So Fc receptor inhibitors would be able to treat all. The ones that are in development are efgartigimod, and the phase 3 trial was positive and published in July 2021 and has been approved by the FDA for use in generalized myasthenia gravis. Rozanolixizumab has completed phase 3 and positive top-level results were announced by UCB in December 2021. Nipocalimab and the Immunovant product have been positive in phase 2 studies and are still under development, but not yet as advanced as the other two. So here, efgartigimod, it just repeats the mechanism of action. It is a fragment, not the entire antibody, and has increased affinity at different pH values. So it has a half-life as shown there, and there's a targeted reduction in IgG subtypes. The study that proved the efficacy of this was a phase 3 study with efgartigimod given every week for 4 weeks, and then a repeat cycle allowed. And a placebo group was obviously given placebo. The primary endpoint was based on the first cycle treatment, in acetylcholine receptor positive patients. The benefit in this study is that patients with MuSK positive MG and also seronegative for both were allowed to enroll. After the phase 3 study, patients were allowed to enter an open label extension for up to 3 years of treatment. So this was an individualized treatment. You see 2 cycles, but the second cycle was only administered if the effect of the first cycle wore off and patients deteriorated on their activities of daily living, the ADL, so that you had to clinically deteriorate to get the second treatments, but that was not the primary endpoint. And this just shows the patients, the overall population, and the acetylcholine receptor positive patients, very similar in age across the groups and in MGFA classes and in their therapies. You can see that 70 to 80% had been on steroid at some time, and a minority or fewer patients had only been on acetylcholinesterase inhibitor therapy. And you can see the patients, there were 19 that were not acetylcholine receptor positive in the drug group and 19 in the placebo group. So the numbers of these other populations are small. And this was the primary endpoint, was the ADL receptors to the left, you can see that 67.7% responded during the first cycle on efgartigimod and 29.7% in the placebo. And then in the second cycle, the responder rate was 70% on drug and 25% on placebo. And this just shows you graphically as well that there was an effect in both cycles, so the response was repeatable. It was only the first cycle that was used for submission for approval to the FDA, and there was enough evidence from that to allow approval. And I think just to show that the mechanism of action of reducing IgG and acetylcholine receptor antibodies was effective, you can see the maximum reduction was by 4 weeks, but the reduction started by the first week. This drug is given intravenously, and there was a significant drop-off in both the total IgG population and the abnormal acetylcholine receptor antibody at week 1. The albumin levels did not change, and that's an important consideration as one of the agents may slightly adjust albumin levels. And the overall population of, had similar reductions in IgG. And this is the Christmas tree plot, which is a favorite way now of showing benefits of treatment. To the right is placebo. What this shows is that as you increase the rigorous cutoff values for the ADL and increase the cutoff values for the QMG, that the placebo responder number drops and the drug group is maintained, so that the benefit in the drug group is shown with greater degrees of change. Minimal symptom expression was achieved in 40% on efgartigimod and only 11% on placebo. And this was those people who achieved an ADL of 0 or 1 anytime during the first cycle of treatment. Now, the other interesting thing is how long the response lasted. In about a third of patients, the response lasted more than 12 weeks, although you might have expected some recovery in IgG by then. In 20% or so, 8 to 12 weeks, and in a very small number, it was less than 6 weeks. This difference in duration is a reason to individualize treatment and perhaps retreat as the patient notices a worsening. That may be one approach, because you're not quite sure how long the effect will be in any one patient. It's not a standardized duration of benefit. And we'll go to now the secondary endpoint overview. And what is important is that multiple secondary endpoints showed benefit of efgartigimod over placebo, including the quantitative myasthenia gravis score improved 63% on efgartigimod, 14% on placebo, and the duration of the more than 2-point improvement in ADLs was longer with drug than placebo. The early responders higher on drug than placebo. So really, multiple endpoints showed benefit with drug over placebo. It was not a simple endpoint. If we look at this in the seronegative, now we're down to smaller numbers, 19 and 19. It gets harder. There was no difference in ADL responders, which was interesting. But on the quantitative myasthenia gravis score, which is a more objective measurement of strength, there was a greater percentage on drug than placebo. And then MDL responders and QMG responders, if you wanted both to meet the definition of response, this was definitely more evident on drug than placebo. And then minimal symptom expression, again, more common in drug, but the numbers are getting too small to really make a lot of inferences from. And if we look at the side effects, they were similar between efgartigimod and placebo. They were mild to moderate and well tolerated and easily treated. The most frequent was headache in both groups, nasopharyngitis in both groups, and then you can see the rest. Infections were slightly more prevalent in efgartigimod than placebo, but not by a large number. And infusion events were actually more marked in placebo. If we look at this in summary, about the same percentage of patients in each group had AEs, serious ones, similar, but maybe more in placebo, and discontinuation from this study because of AEs was the same in drug and placebo. So really, efgartigimod was generally well tolerated by patients in this phase 3 study. Now, FC receptor inhibitors are not the only drug. As I've mentioned, we have complement inhibitors. You've heard about B cell reducers such as rituximab. And I think it's important to remember that with complement inhibitors, MuSK antibodies do not go activate the complement pathway, do not go that way. And therefore, complement inhibitors would not work in MuSK-positive patients. Again, the underlying antibody production is not altered, and you may get rapid return of symptoms. The trouble with B-cell depleters or anti-CD20, this is not expressed on early B-cells, precursors, or late-stage long-lived antibody-producing plasma cells, which are predominant in acetylcholine myasthenia, do not respond to this therapy. And this may be why only about 1 in 3 of acetylcholine positive patients has shown benefit with rituximab, and why the evidence is so inconsistent. It is very consistent for MuSK, but not so consistent for acetylcholine MG. The other things are administration, IV, and then the costs. And then finally, this just shows that there are multiple places to attack with different therapies. And as we go, this is this diagram of immune issues in myasthenia. And as we go more upstream, so complement is at the end where you're destroying the postsynaptic membrane with the abnormal antibody. And as we go more proximally along the cycle, we get more selective and more specific. The cure really is to turn off the abnormal antibody production, and we are not there yet. I just want to mention the other FC receptor inhibitor. Efgartigimod is intravenous. Rozanolixizumab is subcutaneous. Rozanolixizumab, as I mentioned, just announced their high-level positive phase 3 results in December. They will be showing at upcoming meetings, but they showed some changes in their phase 2 study that led to the phase 3 program. So there were positive changes, particularly with 7 milligrams per kilogram administered in 2 cycles of 3 weekly cycles, the first one, and then after the second one. And rozanolixizumab also drops, as you can see here, the antibody levels that are shown in orange and the total IgG, and you can see that it happens, and it starts to happen within the first week, but the nadir is seen at day 36 during dosing period 2. So FC receptor inhibitors are a promising novel treatment. There's a lot of active investigation, as I've shown, and the benefits that we predict are that this may be used in place of plasma exchange, intravenous immunoglobulin, and subcutaneous immunoglobulin. The onset is rapid within the first 2 weeks or 3 weeks of therapy, a little more rapid if it's IV rather than sub-Q, but still fairly rapid, and shows benefit on multiple endpoints in myasthenia gravis. So it will alleviate some of the access issues with PLEX, and maybe better tolerated than IVIG or sub-Q-IG, with lower volumes if you're administering it either IV or sub-Q, and less issues with the possible shortage of immunoglobulin products. So it's a very exciting time.
My relationship with Dr. Bril as my neurologist has been very important to my understanding of the disease when I was first diagnosed, my treatment options at the beginning, and she's the one who guided me through the crisis that I had the year after I was diagnosed. When new treatment options become available, we talk about them to get a sense of what works for me and what doesn't. And in particular with Dr. Bril, I understand that her goal is not to over-medicate me. Her goal is to find the appropriate level of medication that lets me lead the best life that I can lead without overexposing me to the side effects of medication. And it's a very delicate balance. And it's something that we'll probably continue balancing for the rest of my life.
I find that it's a very interesting thing about how we explore outcomes. And Dr. Barnett has taught me a lot in the last few years about how to go about evaluating my patients more comprehensively. And I think one of the issues could be too, the patients adjust to their illness, right? They develop an adjustment. Even if their ADLs are not low or their impairments are not very minor, they come to a stage where they're happy where they are and they don't want to rock the boat and change the therapy. I had a patient like that the other day. I saw him 6 months ago. He hasn't had myasthenia so long. And I had put him on treatment 6 months ago. His impairment scales was the same, and the percent of normal was the same. And his past, like, was this acceptable? Was no. Yesterday, when we did everything, his percent of normal was the same. His impairment scales were the same, but the past had become yes. So he had adapted. How do you think this influences the way we study myasthenia and how we treat it? Are we falling into a placid acceptance of a subpar life that our patients may have? Should we accept that?
I mean, I don't think so, Dr. Bril. I think that we need to strive for better. We need to strive for minimal symptom expression or asymptomatic. I think from the patient perspective, right, they kind of adapt, they compensate, and they become complacent. But I think also from our standpoint, I mean, I think like the both of you and like many people that take care of patients with myasthenia, we're also taking care of people with really untreatable disorders. And I think that we get in this mindset that, well, the myasthenics are doing a little bit better than the patients with other diseases. That's good enough, when really we need to push the envelope ourselves and really, strive for minimal symptoms or asymptomatic state in our patients with myasthenia.
Yeah, I agree. I think it's both. Sometimes it's the patients who don't want to rock the boat. Sometimes it's ourselves. I think it also has to do with the limitations of current treatments that we've had. So when you have treatments that are very toxic, or someone who has not responded or has major side effects to everything, it becomes increasingly hard to go up above when your options are limited. But once you have new treatments and options to explore, that I think should, both for patients and clinicians, make us more likely to strive for that. So I agree. I think what we've seen in recent years is that most patients are not doing that well. Even when you think they're doing well and you really ask patients, they're quite limited, even if they seem okay, right? Sometimes myasthenia is one of those invisible disabilities, because many patients don't look like they have myasthenia. They can walk down the street and they look fine, right? But they're not fine. They walk a few blocks and they get fatigued. They have to stop what they're doing. So I totally agree. I think we shouldn't be complacent, and we should go, and get that one-on-one patient perspective of what it is that we can help them with and improve.
So the other interesting case I had was a man in his early 60s he's had a dramatic improvement with Imuran. He doesn't know he's got myasthenia, he says. But what he has developed is recurrent skin cancers after several years of treatment. And I'm loath to leave him. I said, you have got to change. You've got to come off. I'm going to try you on something else. I just can't, I can't continue to prescribe. He actually pled with me to leave him on Imuran. And his comment was, what? I would rather have 10 years at 90% rather than 30 years at 10%. so, you know, we have to take into account I mean, not that I left him on Imuran, I just, you know, convinced him, but our patients' preferences are extremely important as well. And their judgment of their lives has to be considered, I think. What do you think? What would you have left him on Imuran? Or would you have gone with me and made him stop?
I would not go against you, Dr. Bril. I totally agree with your decision. You know, in fact, you know, I think that you know, the oral immunosuppressants have done a great job for many a patient. I have many patients in, you know, who like your patient are asymptomatic, but I do worry about side effects. In fact, I had just published a case report of a patient who I had in basically minimal symptom expression on mycophenolate for many years, who developed CNS lymphoma related to this mycophenolate. So thankfully he's doing well, thanks to my colleagues in neuro-oncology, but now I'm a little scared. I realize it's a rare occurrence, but certainly it makes me a little gun shy. And I think that, you know, looking at future therapies that might be a little more kinder and gentler in terms of side effects, both short and long term, it really gives me pause.
I hope that the future holds anything and everything that I want it to hold. You know, I don't believe that myasthenia will shorten my life, and I hope that it doesn't drastically impact the quality of my life. You know, I do have fears over the rate at which I might get cancer due to the immunosuppressants that I take, and that is more likely probably to impact the quality or length of my life. But until then, we cross our fingers and listen to our doctors.
I'm happy to conclude this session unless you have any other closing remarks, Dr. Bril.
No, I would just like to thank my colleagues for excellent presentations. Thank you.
Thank you.
Thank you for coming.
Yes, thank you all for everything you've put into this. And from the CME Institute, we thank all of the participants as well as the faculty, and invite you to please complete your post-test and evaluations and seek your CME credit. Thank you.